All right, assalamu alaikum warahmatullahi wabarakatuh, everyone, for attending MPN's Vasculitis of the Foot and Leg, presented by Dr. Mariyam Abbasi, who is an attending surgeon at Brooklyn Hospital Center. And I hand off the floor to her. Bismillah.
Hey guys, good evening. Assalamu alaikum. Sorry about the technical difficulties. So I'm going to try to keep this presentation short and concise and to the point. I have a pet peeve for long presentations and long speeches at weddings. So trust and believe this will not be too long. Okay. Thank you for joining us this evening. So this case is not something that I saw in my practice. It's something that was seen in a personal circle of mine that I saw up close, and I wanted to share it with you guys. And I think as podiatrists, we're so used to seeing the typical, heel pain, plantar fasciitis, Achilles tendinosis, that I think sometimes it's good to see cases that are rare, that we don't see on a day-to-day basis, just so we're aware of it. So when it does come into our office, we know how to diagnose it properly. So let me talk about this case. We had a 15-year-old male who presented to the emergency department with a purpuric rash, which I will share pictures shortly. Bilateral feet and lower extremities. His rash developed and spread gradually over the course of a few days. This was associated with extreme gastric pain. He had 2 episodes of vomiting done within 24 hours. His vitals were within normal limits. Intense abdominal pain, extreme weakness, and nausea present as well. No other past medical history, by the way. Completely healthy young male. This video started. Okay. Can you guys see the video? Hello?
Yep, it's working.
Okay. So this is what it looked like. This is it was a palpable purpuric rash. Started at the foot, worked its way up. This is all that he allowed me to record. And like I said, it gradually spread up. This is not him, but this is just other manifestations and pictures of the disease. And it worked its way up into his torso, abdomen, chest, arms, back, neck. Just another picture, another example of what it looked like when he got angry. Additional clinical information about this patient. Unfortunately, the kidneys did get affected. The lab showed some proteinuria, hematuria. His ESR and CRP were elevated. I don't remember the exact numbers, but they were mildly elevated, nothing too crazy. All of the lab values were unremarkable with the normal limits. He did have, this is important, a previous history of a URI 1 month prior to this diagnosis, which subsided by itself. It was just a minor viral infection, didn't think anything of it. The abdominal ultrasound was done in the emergency room and no significant findings as well. Any guesses, thoughts? Ideas? Anybody? Let me log on to the main screen. Can you guys hear me?
Yes, we can.
Okay. So does anybody I kind of want to make this an interactive discussion if we can. Also, anybody have any thoughts or ideas or?
Do you mind going back to the pictures?
Sure.
I think you'd want to consider any allergic reactions possibly, or with possible petechial. I know you said it was raised, but you also want to consider thrombocytopenia.
Correct. And that was initially what was one of my differential diagnoses when I saw this. But then he has these concomitant issues as well, correct? He has significant abdominal pain. He's vomiting, nauseous. And that was something that I kind of said, okay, well, labs were fine. Kidneys were affected. So, okay, well, diagnosis is Henoch-Schönlein Purpura, HSP, also known as IgA vasculitis. Not something we see very often. I combed through the literature. There's nothing in regards to podiatry related HSP and lower extremity. Journal of, American Journal of JAMA and stuff. They have that because obviously they see it on a larger scale. But just something for us to be aware about, okay? And this disease specifically, this type of vasculitis that I'm going to talk about, it's a small blood vessel vasculitis, okay? And it's due to IgA deposition. So for the medical students here, I think in your immunology class, you learn about the 5 different various antibody classes, right? You have IgG, IgA, IgM, IgE, and then IgD. So this one specifically is the IgA-mediated vasculitis. Essentially, what's happening is that the antibodies are attacking the immune system. It's an autoimmune disease, okay? And it's affecting the inner lining of the blood vessels, the tunica intima and the tunica media, okay? What happens is these immune-mediated complexes are depositing themselves in the blood vessels, and the blood vessel thins over time and causes the blood vessel, essentially, it's leaking into the surface of the blood, causing this raised purpura rash that we see. And IgA, we see it in significant amounts in the saliva. We see it in the lining of the kidney and the GI tract and the mucosal tract. That's why this particular patient, we saw those clinical manifestations such as kidney disease, gastric symptoms, and he had, like I said earlier, a URI. Okay, and it's seen commonly in boys ages 10 and younger, but for whatever reason, he was 15. He's a teenager. This happened to him, and we don't know why. Okay, there is a slight genetic component as well. He did not have any joint pain. Okay, surprisingly, but everything else was a check for him: the purpuric rash, the abdominal pain, and the unfortunate kidney involvement as well. So he was placed on 20 milligrams of prednisone for 30 days, tapered down. I think it was 10 days of 20 and then another 10 days of 15. He was tapered down for about a month. Most kids recover. They do great for self-limiting disease. Unfortunately, some small amount do develop kidney complications, which is what happened in this patient. We had to take him, he was taken to a pediatric nephrologist, and the rash continued to spread to the rest of his body over the course of the next month, okay? And it got angrier. So obviously, it became worrisome. He was put back on prednisone, the same dose, for an extended longer period of time, for another 15 days. At that point, we had complete resolution of the rash. Urine sample was negative. The nephrologist also did another ultrasound, which was also negative. So that was a relief. For the purposes of boards, okay, because I don't think as attendings we don't really have to know this to that extent, but there's different types of vasculitis, okay? We have the large vessel, the medium vessel. This specific one is a small vessel, okay? I remember on my boards, I had a question about Takayasu, and that's typically, you see that in Asian females, 40 and younger. So that was the keyword, but that I remember was on my boards. And then giant cell affects the temporal artery, so you have the unilateral headache. Kawasaki, I actually saw that when I was a new attending. I have a picture on that as well. Polyarteritis nodosa, also it's autoimmune. And then the small vessel, you have the rheumatoid, lupus, HSP, which are all as well autoimmune. We have the different types of vasculitis. Again, there's several different kinds. Feel free to read up on these at your own leisure. I just wanted to go through something that I saw, that I experienced, that I wanted to share with people, with you guys. Another slide again, talking about that. So Kawasaki, this is something, like I said, I saw as a new attending. I was just a couple of months out, and it typically affects boys more than girls, but I specifically remember this patient. She was a 13-month-old baby, and she just came in with red swollen feet and like a purpuric rash on her feet. Okay, no fever, none of the other symptoms that you see here. So you're thinking, okay, cellulitis, right? So I sent the patient to the emergency room. Patient ended up getting admitted. They did some tests, and I remember the diagnosis was Kawasaki. So this was something that I remember stood out to me. Anybody have any questions, by the way? Am I going too fast? No? Okay. You guys can hear me, right?
Yeah, alhamdulillah, you're doing really well. I did have a question. I guess when you initially think like something to be the diagnosis and then it turns out to be something else, like how does one navigate that? It must be like kind of a difficult kind of state of mind, because all of a sudden it just is different from what you thought initially.
Yeah, and that's why when you see these types of vasculitis, right, it's very easy to misdiagnose it. Okay, like thrombocytopenia, that easily, that could be a differential diagnosis, but you have to correlate it clinically with other symptoms the patient may be experiencing, like extreme GI upset, joint pain, right? You don't see those in thrombocytopenia. So then you're kind of thinking about other things, right? And then we say, okay, when you hear horse beats, think horses, not zebras, but sometimes you have to think outside the box. I mean, you see something like this, and you don't see this too often, at least I don't see it too often, but it is a good differential diagnosis to have in the back of your mind.
Thank you.
And then I have one last slide. As far as treatment options go. So, like I said, the patient was placed on high-dose steroids, and luckily he was good to go after that. It does come back in 50% of young kids, is what most pediatricians say, and rheumatologists say. And IVIG also is another popular form of treatment, not just for vasculitis, but also in Guillain-Barré syndrome or anything autoimmune related. It's essentially a blood transfusion, but you're just getting fresh antibodies or healthy antibodies administered into the blood to help mediate the immune system, to help calm the immune system. Then there's interferon therapy. Then you have immunosuppressants if necessary, if it gets in that level. But that's more of the rheumatoid, lupus, and so whatnot. So that was my quick and short case presentation. I hope you guys learned something today. And if you do see these questions on the boards, then you can remember. Oh, I remember Dr. Abbasi's talked about this. Do we have any students here? Who's here? Who here is a student?
I'm a student.
Is that Samia?
Yes.
Okay, you're Samia. Okay, you're a student. Yeah. Any attendings besides? I know Dr. Farhan and Dr. Sheikh here.
I'm an attending. Jacob Nasser. I'm out in Kentucky. I'm in my second year of practice.
Okay, nice. Yeah, guys. So like I said, this is short and sweet. And any questions, comments?
Yeah, I'm glad you shared this. Jazakallah for taking the time to do this presentation, because these will, if not in clinic, these scenarios will show up on, board questions and stuff. We love writing about these things. So
Yeah, right.
It's good to know. And it's always good to know, because that one patient that you do see, it should definitely be a differential. And that question that was asked earlier, like how, with experience, of course, that your diagnosis likely will, be correct, but then you should always order the correct stuff or do the correct referrals to make sure that you rule out the other possibilities too. So this is why when you see the wounds or vascular, like, the things like, oh, this is a chronic wound, okay, whatever. Well, you should be thinking, should I biopsy this? Should I, how's the vascular status? Like all these things should be going in your head. So I think with experience, that's, it comes with that. That's becomes your second nature. So,
Right.
but it's good to see this.
And one thing I wanted to piggyback off of you, Dr. Sheikh, is don't be afraid to refer out, right? Like,
oh, absolutely. I am, I'm triple certified, right? And I still refer things out because I'm like, okay, I'm not good at this, or I don't do a lot of this, or I don't enjoy doing this. And I always say, go ahead and get a second opinion, especially when it comes to surgical stuff. So definitely never let your ego come in the way of your practice. So definitely refer things out for sure. And get opinions. Consult other people. Ask your colleagues. There's no harm in doing that. We all have our knowledge sets and we can all contribute, to helping each other. There's no shame in doing that.
Especially with kids, I tend to be overcautious with children. Just because the pediatric population is different and there's more lawsuits with them, and parents tend to be more anal with these types of cases. So, but definitely with pediatric patients, you want to have your guard up.
For sure. For sure. Any case, and sometimes you run into dead ends. You're like, okay, I have done this and this and this and this. And, maybe there's that one thing that one of your colleagues has done that can, change the course of treatment, or maybe you can offer that or refer them out to this other, modality. So always don't be afraid to talk to people, your colleagues. There's no harm in that. Yeah, I'm big. I always, text people for their opinions and professional advice. I'm like, hey, I did this and this and this. Do you think there's anything else to do? So.
Yeah. And the other thing is when this rash was first noticed, we said, okay, let's take him to a podiatrist. Let's go to a podiatrist, And then the next day is when the patient started vomiting and, significant symptoms showed up. So we said, okay, there's something more than just a dermatological condition going on. So if you do see this in your office, like I said, think zebras, think outside the box.
Did anyone else have any other questions or comments? Here's one thought, like in terms of like getting second opinions from like colleagues or other people in the field, how would you go about doing that? Like I think it was mentioned that Dr. Sheikh would like text people. Is that like that sounds really cool. Like you can do that. Like I know I'm a first year, I don't know much, but you can just
everybody works in a different academic setting or clinical setting. I work in a hospital, and so we have a multidisciplinary approach, and I can refer them easily. If somebody is in private practice, if you want to share how, I'm sure they've built up referrals, most of them, they've built up connections from colleagues, or they get a lot of referrals, like I said. But I work in a hospital setting, so it's very easy for me to send these patients out.
You're a first year student or you're a first year resident?
I'm a first year student in school, so
Yeah.
not
Okay. So, as you go through school, right, you're going to have your clinical rotations with your colleagues in your third year. In your fourth year, you're going to meet, make a network of people that you meet on externships. Then you're going to, inshallah, go to residency. You're going to have your core residents, right? And then when in practice, like you'll have those people. So it's like building your network, and it's not anything extraordinary. I worked at NYCPM for 10 years. And even my department chair or even my senior colleagues, like even they would say, hey, Reem, you learned this thing. Tell me, should I be doing it this way? Is this newer technique better? Or I would be like, hey, this is my game plan for this case. Do you think I should add another procedure? I'm thinking of making the incision this way, that way. So you build your network of people over time. And I mean, Dr. Abbasi and I often will, reach out to each other. We didn't go to school together, but we connected, later on. So you meet people and you learn from each other. And you'll see that as you progress through your career, inshallah.
Inshallah, Jazakallah khair so much for sharing your wisdom. That's so incredible to hear, especially when you're so early on. Jazakallah khair.
Yeah. At this point, I would just focus on grades and learning as much as possible.
Sounds good, inshallah. That's all I had. If anyone else wants to chime in, otherwise, I think it was incredible. Jazakallah khair so much for doing this and teaching us all quite a bit, I think.
Okay, guys. Have a great night.